Hello, everyone. Sorry for the brief delay in unmuting. Welcome to the second day of the Frontiers of Entrepreneurship Conference. It's great to have all of y'all back who participated yesterday, and wonderful to have those of you who may not have been there yesterday. So I'm Vicki Gibbs. I am the Executive Director for the Entrepreneurship Center at UNC Kenan-Flagler, and we are very excited to partner with Greg Brown and the Kenan Institute, as well as our academic partners and sponsors, to bring you this Frontiers of Entrepreneurship Conference. We're also excited to partner with the Kenan Institute to bring you the Trends in Entrepreneurship report. We launched our second annual report yesterday, so if y'all have not downloaded it, I encourage you to do so. You can access it via the chat. I think Sydney's going to put a link in there, and you can also access it directly from the agenda. So we've tightly integrated the report and the conference this year. So as you are in a panel session, you can see on the agenda the exact section of the report that it refers to. So I encourage you all to dig in. So I'm going to introduce the conference today and talk to you about two things. The first thing I'm going to talk to you about is community. If you were in yesterday's session, you heard me talk about the fact that entrepreneurship is not a solo sport. But when it comes down to it, life isn't a solo sport. We exist in communities together to learn. One of my favorite quotes is, "As iron sharpens iron, so we sharpen each other." And that is the opportunity we have today here at the conference. So this is a really unique group of people that you'll be with today. We have people from academia, we have people from industry, and we have people from government and policy. And this conference brings us all together to talk about the most relevant issues in entrepreneurship. So I know we've all been in on a lot of Zoom meetings. People have become very efficient at multitasking during the Zoom meetings, but I really encourage you today to shut down the other things and lean in. You're going to be able to ask questions during each of the panel sessions with our Q&A feature. And you can also connect to the other people. So I do want to challenge y'all today to connect with one new person. Now you may wonder, well, how do I do that? I'm in Zoom. Well, we actually have a few opportunities for you. So at the end of today, we're actually going to be doing a networking session. And we're going to have two different Zoom rooms set up so that you can do small group discussions. And those small group discussions will be around the two panels today. So stay online, engage with others that way. If you're not able to do that, we also have a LinkedIn group for the Frontiers of Entrepreneurship Conference, and we're also communicating on Twitter. So our Twitter handle is #KIFE2021. So there are ways to connect, and I challenge you all to do so. So the second thing I want to talk about today really sets up our two panels today, and it's about the global pandemic that we are all still experiencing. Now, I don't want to minimize the negative impacts that the global pandemic has had. There have been lives lost, jobs lost, businesses closed. But there is also some good and opportunities that have come out of the past year. And two areas that have seen a tremendous amount of innovation and change are the two panels that we're covering today. The first one is health innovation. That one is led by Makamoan. And in that one, you know, we've had all of the innovation with COVID research and the vaccine and delivery, but there's also been a whole host of innovation around data analytics and health, around AI and machine learning and how those are applied. So that is, I think, a great way for y'all to really sort of dig into what's going on and is being disrupted in the healthcare industry with some of our experts. Now, the second panel is looking at a second issue that we have all dealt with this past year, which is remote work. Now, with this shelter in place and everyone having to work remotely, we've had to learn new skills, right? And we've had to adapt as organizations. For entrepreneurs and for small businesses, this has provided a number of opportunities. So one example is a friend of mine who's actually a CEO of an ed tech company locally. He actually was looking for people, you know, with ed tech experience, but that he was limited initially to this region or would have to relocate people. He's now started recruiting from across the US and can more quickly and with more depth fill those positions. Another example is a good friend of mine. She was just hired as an SVP of product for a growing blockchain company that is based in the Midwest. And so now she is a new executive team member that is working remotely. So we're seeing this trend that's happening across a lot of entrepreneurial businesses. And we're also seeing it in investments that they're not rooted to their regional location. So these are opportunities for entrepreneurs. And our second panel today is going to dig into those issues. So without further ado, I am actually going to turn it over now to Maka Moen, who is one of our great professors here at UNC Kenan-Flagler, and she is going to lead us through this next panel. Take it away, Maka.
Hello, everyone, and thank you, Vicky, for the introduction. My name is Maka Moen. I'm an associate professor of strategy and entrepreneurship here at the UNC's Kenan-Flagler Business School. I joined Vicky, Greg, and everybody in welcoming you to the Frontiers of Entrepreneurship conference. And we're so thrilled to have you with us today. As Vicky described, yesterday was an amazing day of learning and reflection on a number of different topics. And as we kick off day 2 of the conference, I hope that we can continue with the same energy and spirit of learning and action. So I'm pleased to introduce our panel for today, Health Analytics and Entrepreneurship. For those of you who are conference veterans or newcomers, you may know that one of the recurring themes of our conference is emerging technologies. And every year we pick one particular technology and have a spotlight on it. And this year our focus is on health innovations. Of course, the rapid pace of technological innovation has opened a new era of wellness and medical treatment for all of us. But as Vicky alluded to, the sober reality of our global community going through a pandemic in the past year is not lost on us either. And throughout the past year, time and time again, our communities were filled with hope and power as we heard about various technological innovations in healthcare. But if we reflect back and look at history, these are not exceptions. This has been actually the rule in the area of medical innovation. As we look at the COVID vaccine being one of the quickest vaccines to have been introduced, we can think about other public-private partnerships throughout the history that have brought us other amazing medical drugs. As an example, during the World War, after realizing the immense need for having infection treatments, the government put through the OSRD a program to deliver the next medical drug that we're now benefiting from today, the penicillin. The news that we heard from hospitals that doctors and healthcare providers were tweaking ventilators to be able to increase their effectiveness and scale in health delivery is again nothing new. This is what doctors have been doing every day at the front line of innovation in medical devices, leveraging the knowledge that they've had with respect to how those devices can be refined and improved. They have been the user innovators and entrepreneurs in that era. And I know we're all cheering that Merck and Johnson & Johnson put their competition aside and they're helping with the manufacturing of the vaccine. That is, again, have been a pillar of healthcare and medical innovation. Collaborations have been the norm in the industry. And indeed, many of the benefits that we're getting is the result of that. So with all of this, as we're cheering and celebrating many of the achievements that have actually gave us power and hope over the past year, we decided to use the opportunity to have healthcare as the spotlight for this year. The particular focus of our panel is on health analytics, but as you all know, like alongside with all of these panels and conference sessions, we're releasing this year's Trends in Entrepreneurship report, and it has a special segment on health innovations, generally not like limited to health analytics. So let me walk you through some of the most interesting and exciting trends that we actually observed there. And I invite you to check the report at much more length because we have many more like other issues there. So I'll share my screen. We have been looking at healthcare industry from two perspectives, medical devices and pharmaceuticals as like two different pillars of the industry. And of course, throughout the past couple of decades, as we look at the share of healthcare spending in general in the economy, this has been an increasing share. So this is no surprise that healthcare innovation has also received a lot of attention. One of the trends that we do see coming up until 2020 is that health tech startups are receiving really high levels of private capital investment. And with the SPACs being the most recent way to capture economic value out of these opportunities, those are also becoming very important. So to look at some of the private funding trends in healthcare, this has been an increasing trend, as I said, very much relying on private funding. But regardless of this vibrant increase in spending in this area, it looks like that health tech unicorns actually are looking at exit options through SPACs and not necessarily IPOs or the traditional ways. Putting aside the financial and funding trends in this area, the nature of innovation outcomes in this area is also very important. One of the things that we can look at is like the vibrancy and the general side of pharma industry in particular, that has accounted for 10% of overall R&D spending in the economy, with an increasing trend of roughly 3% annually. And you look at the revenue that's been generated in this industry, $205 billion, again, on an annually increased trend. And looking at where this revenue is really coming from and what those R&D expenditures are really leading us, looking at the number of patents that have been filed in the area of pharmaceutical drugs, we do see a pretty steady rise in the past decade. But there has been some sort of bump and a decrease around the time of the recession in 2008, but thankfully a great recovery after that. And this maps nicely into how actually research collaborations in the biopharmaceutical industry have also trended. We did have a very healthy level of collaborations before the recession of 2008. And again, the slowness that we experienced in those years had a great comeback. And these trends are particularly important because if you think about the outputs of biopharmaceutical industry being the drugs that are introduced into the market, research collaborations and patents are really lead indicators of where the industry is going on. Many of these collaborations are where companies get together, share their resources and technologies with the hope to offer new products. And then those patents are really the foundational building blocks of potential molecules and processes that are then embedded in introduced pharmaceutical drugs. So if we don't have these leading indicators, then it's very difficult to see drugs later introduced in the market. So these are all very promising trends. Now, looking at some of the outputs with respect to drug pipeline and drugs that are currently under development within pharmaceutical companies, there has been a steady growth, even though probably a lot of these drugs in development will not go through stage 2, stage 3 clinical trials, but this vibrancy is really pointing to the health of the system overall. And looking at therapeutic areas that have been the focus of the pharmaceutical industry in general, we do see a pretty distributed attention towards many of the therapeutic areas, with a particular area being anti-cancer drugs receiving a lot of attention, and second being neurological therapeutic area. So that's interesting that these two areas have received the majority of attention with respect to drugs in development. But what these numbers are masking really is another very important trend that's happening in the background. And that is three methods of drug discovery and development that have been introduced in the past decade: AI-driven drug discovery, CRISPR gene editing, and mRNA vaccines. And I want to highlight this for one particular reason, because yes, we can count the number of drugs that are introduced into the market. We can count the number of patents and look at those increasing trends, but these are really methods of drug discovery that if we can see any type of revolution and change in them, then the accelerated rate of drug discovery will come after them. These are methods that can act as multiplier effects throughout the system. And we have seen some of the historical trends in the past, where in the late 1970s, recombinant DNA technology brought the biotechnology revolution and really shifted the pattern of drug discovery from chemistry-based experimentation to real understanding of recombinant DNA. We did see a lot of new drugs, a lot of therapeutic areas that did not receive attention beforehand really come to surface. And these three trends that we have here as enabling technologies as really methods of drug discovery gain importance in that spirit. And if you want to look at a couple of them, let's say AI-driven drug discovery, actually investments in AI are now receiving like the bulk of the attention. Respect to all the areas that you're being invested, healthcare is really front and center. And some of the major achievements to cheer, we've probably heard stories of AlphaFold or the CASP system out of universities coming in that have really revolutionized the way we think about drug discovery and how effective these new methods are. Along that, CRISPR gene editing is this other enabling technology that came out of that was actually rewarded with a Nobel Prize in the last year, which is amazing. And you do see from the numbers here on screen in terms of how vibrant both the upfront, like scientific discoveries, like publications and patents are, and then on downstream, like practitioner side of it, how many companies and clinical trials are currently going on in this area. And as we're all benefiting from mRNA vaccine development, of course, this is another very exciting area that has the potential to shift the way we think about vaccines moving forward. The other sector in healthcare is medical devices. Another quick glance about this industry, again, shows very healthy trends with respect to investments and fundings that has been received. Again, innovation, the rate of patent applications had seen a similar slump thinking about the recession years, but had a quick recovery afterwards. Similarly, collaborations in the medical devices sector, similar to pharmaceuticals, have seen a similar comeback after the recession. Two other charts that I want to direct your attention to relates to medical device approvals and what we see. In the US, there are two categories of medical device approval. One are for refinements to existing models. That's the one you see here on the left of the screen. And we did see a decreasing trend there. But to the extent that it relates to class 3 devices that you see on the right side of the screen, the numbers are going up, and these are really the novel medical devices that are introduced in the market. And all of you, with respect to the enabling technologies that are changing medical devices, I'm now wearing my Apple Watch. Many of the other attendees here may be using and benefiting from different digital trends and connectivity in this area again, which are promising trends that have the potential to really shift the landscape here. So with this, I hope that I've gave you a very overall general view of where the trends in the healthcare sector is going. Again, I invite you and encourage you to check the report. There are many more trends listed and documented and actually interpreted there. With this background, let's have our spotlight and check on health analytics as a particular area that has been receiving a lot of attention and has actually helped healthcare providers and firms to reimagine the workflow of providing healthcare in the society. And John Fjeld who is here with us, will lead this session as the moderator. Dr. Fjeld, I'd like to introduce him first as an alumni of the University of North Carolina. Then after which he has moved to become a professor of strategy, entrepreneurship, and philosophy at the Duke University. And John is currently the Director of Innovation and Entrepreneurship Initiative at Duke, which is a university-wide initiative to really increase collaborations between student, faculty, and other stakeholders in this area. John, we are privileged to have him on the panel, given the immense expertise, not just on the academic side and his knowledge in that area, but the deep expertise and experience in leading entrepreneurs himself in healthcare and beyond. So John, the virtual stage is yours. Thank you.
Maka, thank you so much. It is such a great pleasure to be with you and to be with everyone. And first, I have to say thanks to you and to Chris and to everyone for putting together this report. I think it's such an excellent piece of work and a wonderful contribution to our field. So I really encourage everyone to take a look at it. It truly is a great piece of work. And also thanks to Vicky and Greg and everyone for organizing this conference. You know, we miss being together in Florida, but done a great job and really appreciate it. You know, we all know that data analytics, machine learning, et cetera, is exploding and coming into so many parts of our lives, but nowhere is there the potential for more impact than in healthcare, how healthcare is delivered, access to healthcare, tailoring of healthcare. So this is such an important topic for all of us, and especially those of us involved in innovation and entrepreneurship. I think we have a terrific panel today, people with different perspectives and different views on this. So I'll introduce the panel very quickly, and then we'll have brief remarks from each of the panelists, followed by a little dialogue, and then we'll open it up for general Q&A. So our panel is Aaron McKethan, who is General Manager of New Ventures at Aledade and Senior Policy Fellow at the Duke-Margolis Center for Health Policy, which is one of our sister organizations at Duke. Welcome, Aaron. Gillian Munson is the Chief Financial Officer at Iora Health and a venture partner at Union Square Ventures. Then Cobb Payton is the Professor of Information Technology and Analytics at North Carolina State University. So we have all the, or most of the universities represented. And finally, Brad Staats is a Professor of Operations and the Faculty Director of the Center for the Business of Health at UNC's Kenan-Flagler Business School. We are going to begin with some observations from Brad, who is going to set up one of the problems to be addressed potentially by analytics. Then we'll move to Gillian, whose company is trying to take advantage of data analytics to deliver healthcare in a new model. And then we'll get some comments from Faye and Aaron, some cautionary words on the application of data. So I think that should be very interesting, and then we'll see where the dialogue goes. So without further ado, Brad, please maybe introduce yourself a little more fully than I did, and then what do you have for us?
Sure. Thanks, John. And thanks, Maka, Greg, Vicky, everybody for organizing. I am Brad Staats, faculty here at Kenan-Flagler, lead the Center for the Business of Health, and spend a whole lot of time thinking about really learning in healthcare. And today, as John mentioned, I want to talk a little bit about what I see as a fundamental challenge in healthcare that I think analytics, innovation, entrepreneurship are all necessary for us to move forward. So, Maka mentioned kind of the incredible success of the COVID vaccination, COVID vaccine discovery process, right? In December, the US FDA approved the Pfizer COVID vaccine. With this action, the world had its first approved vaccine. 1 week later, we had our second with Moderna's approval. And both of these vaccines far exceeded our initial expectations, right? With efficacy greater than 90%. And these were incredible innovations that were really a testament to the hard work and ingenuity of numerous individuals and organizations. Yet 1 month later, despite the fact that the COVID-19 pandemic continued to have a meaningful health economic impact on the world and on the US, fewer than 5 million people in the US had actually received a vaccination. And this rocky rollout was not due to a lack of time, right? Vaccine candidates had been progressing through the discovery and testing pipeline for months. When attention shifted from creating remarkable new healthcare to delivering it, the system stumbled. And I want to suggest that this is a core problem that we face in healthcare today that I would label delivery neglect, that we focus on the treatment and we ignore how it's delivered, and that this is pervasive in US healthcare. And that healthcare in the US is really a study in contrasts, that patients across the world who can afford to do so, rush to US institutions, such as many of our own or others like the Mayo Clinic or Cleveland Clinic or Hopkins, in order to have complicated, almost impossible to cure ailments get addressed. And whether this is due to investments in technology or employing the best and brightest clinicians and researchers, much of American healthcare is rightfully considered world-class. If you look at our cancer survival rates as an example, they're some of the highest in the world. But while it's true that many of our healthcare organizations do a great job at this frontier of medicine, performance looks far worse in the overall context of care. Despite the fact that our per capita healthcare spending far exceeds the rest of the world at around 18% of GDP, health outcomes in the US often lag those in other much lower spending nations. US life expectancy at birth, for example, trails 25 other OECD countries, and mortality trails 28 other OECD countries. Whether it's skyrocketing obesity rates, incidence of diabetes, cost of various surgical procedures, the US healthcare system is too often delivering subpar quality at a high cost. And so like many things in healthcare, delivery neglect, the good news is it's a condition that can be treated and perhaps even cured, right? But for us to do that, we first need to understand it, which I want to talk about very briefly, and then start to explore how do we do better, which I think this panel is going to be a great way to do that. I would highlight kind of 4 drivers around why delivery neglect occurs, and I think innovation and analytics are going to help on each of these. I'd use the acronym SICK to capture it, so SICK. First, we've got status differentials in innovators and innovations between healthcare and delivery. That traditionally those who create the new product innovations are rewarded with higher status. Those who focus on the delivery that get into the data are often seen as second-tier participants, and yet they can fundamentally drive the experience. The I incentive misalignment, we can think about fee for service. We've got short-term payment approaches. We've got a lack of measurement, at least those latter analytics well suited to address. Third, we have the complexity of healthcare, whether that's the human body, healthcare being nested in social systems, right? Social determinants of health, drivers of health, complex healthcare system design, all things that analytics can help us unpack and really understand, what are those key determinants that are going to help us get delivery right. And then finally, knowledge asymmetry and gaps, whether that's just the difference in the immense training that professionals get, part of it, but also, individuals know their situation, know what they want, know their bodies, and how do we capture that information and bring that in? How do we improve the transparency of quality and cost and help people understand cause and effect, all things that analytics potentially can help us address. So when we think about kind of dealing with that problem of sick, dealing with delivery neglect, there's a chance to really take advantage of the confluence of technology, consumerism, and analytics to help us deliver digital solutions, to offer strategies to help organizations really leverage these approaches to care delivery. Want to suggest that kind of thinking new in terms of partnership. Some of it will be entirely new organizations stepping into delivery. A lot of it's going to be our existing players partnering in new ways. So we can think about kind of a triangle. How do we forge new partnerships between existing providers in healthcare, new entrants, be they entirely new startups, be they the Amazons, the Best Buys, the Walmarts of the world who are doing a whole lot. And then finally, patients, the consumers, right? And if you build that triangle out, how do we think about ways to support them, to understand them better, to innovate, and eventually, right, tying all of this through kind of the data, what's the story telling us? So with that, let me kick it back to you all excited for our discussion.
Brad, thanks very much, Gillian. That was very thoughtful. Gillian, how are you addressing these issues?
Sure. Hi, everybody. I'm Gillian Munson. I'm the CFO at Iora Health. And, you know, a lot of what Bradley was talking about is very relevant for us. So for those of you who don't know Iora, we are a primary care provider. And we focus on the Medicare Advantage population and increasingly direct Medicare as well. Our business was founded 10 years ago by a doctor who believed that people were really undervaluing the power of primary care. And our view is that proactive, high-touch primary care can significantly reduce cost over the longer term in healthcare. And so our business has been based around that concept. The people have tried these things before. And our view has always been that having excellent data analytics and an understanding of populations on a larger scale basis can really help us make that primary care really be powerful. When I think about Iora, you know, one of the stats that really sticks out to me is that our patients end up in the hospital 40% less than the Medicare standards. And we think that's really powerful for two reasons. One is a cost issue, which I'll come back to in a sec. And the other is that our patients don't want to be in the hospital. They want to be with their families. They want to be enjoying their lives. And so we view it as our job to help them from a primary care perspective, do the things every day, the easier small things you can do every day to keep you out of the hospital longer term. For sure, our patients end up in the hospital when they need to be in the hospital, when there's a real medical need. But our role is around helping them live a healthier life, which in our experience, and now I'll get to the data, and then I'll come back to cost in a second, is about figuring out what leads to a healthier life. And at Iora, what we have found is frequent interaction. We interact with our patients 19 times a year versus the average out there about 4 to 6 times a year for these types of patients. We really believe that mental health matters. Our data shows that when we're engaging with patients in person and with mental health capability, it significantly reduces their downstream use of the system. And so we, when we started our company and in terms of how we invest in our company, I will say, I shouldn't say we so much, I've been at the company since January, but some of the first employees the company hired were technologists and data scientists to make sure that we're looking at data and using data to make this both a sustainable business and a business that really serves patients. And our tag, the way we talk about our company is restoring humanity to healthcare. But underneath that is a very important data asset to help us understand both how to make that happen in an effective way to reduce costs and also to make our patients happier. Just in terms of cost, and this is just rough numbers to give you a sense of how this works, our average patient typically is delivering revenue to us of about $1,000, a little under $1,000 per member per month. One hospitalization is on average at a minimum $10,000. So if you're making $12,000 a year to take care of a patient, you're seeing them 19 times a year. They likely have other medical care that's happening in addition. That one hospitalization starts to significantly eat into your ability to pay to see them 19 times a year. If they go back a second time, you're now losing money on that patient. And so there's also an economic issue here of the hospitalizations, which I'm focusing on here. There's lots of other examples, but hospitalizations in particular are so expensive for this category. And again, our main goal is to provide wholesome 360 primary care that gets people healthier so they're not using the system. And we're keeping them with their families, living in a lifestyle that they would prefer versus in and out of the hospital. So that's essentially how we think about the business. Implicit in our business is a very important data asset that we are constantly looking at to make sure we understand what trends are. Coming out of COVID is a whole new world for us, and understanding, what are the statistics around when we see patients, how soon after they've been hospitalized or have had an outside of our 4 walls medical appointment, how often do we see them? We look at this data all the time looking for a new insight into how we can provide better care. And then we deliver insights to our care teams to help them understand how to do the very human interaction with their patients every day in the field. So that's Iora, a little bit of a snapshot of Iora and what our approach is, just in terms of the realm of the, multi-trillion-dollar market that is healthcare. Primary care is a very tiny drop in the bucket cost-wise of the overall health care system. And yet we think it's one of the most powerful places to start with patients. And when we all think about the business, we think about what is the primary care we'd want our parents to have. I think about it in terms of what my parents would have, but I also increasingly in my own experience think about what I would want to have in terms of a primary care team that really understands all aspects of my life and is helping me manage my overall care over time so I can live my best life too. So thank you. That's Iora, and I'm looking forward to the Q&A.
Thank you. Thank you very much, Gillian. Very interesting approach. Now we'll move over to Faye to give us her thoughts on the use of data in healthcare delivery. So please, Faye, take it away.
Thank you, John, and thanks for having me here today. I just want to piggyback off of something that Gillian mentioned, which was primary care being a central focus, which I think I applaud you for that work. What is interesting to me, I'll make an observation, is that when we looked at the trends report in healthcare, there were two foci. One was on medical devices and one was on pharma. Neither was on primary care, right? And so I think that sort of centers where this whole business of analytics is going. And just to give you this backdrop, a few years ago, some colleagues of mine at NC State, we did a study. We did a study and we looked at health disparities, and we decided that we did not want to look at health disparities individually. However, we wanted to see how did comorbid conditions manifest themselves. And so I think analytics, and particularly this AI world that we're moving in, we are going to have to look at how conditions cling together to tell a story. Our story was we were really interested in how did this data manifest itself to show patients' involvement with mental health services and those services for patients that were living with HIV. And we were looking at length of stay and cost of care. And what we learned was that having mental disorders generally resulted in a lower cost in both length of stay and total charges. But patients with mental illnesses are more likely to be transferred to other facilities. And what's the story in here? And the story of the analytics, as we said, was actually length of stay will not be observed. This dovetails with sort of these recent, I'd say, studies that are taking place, particularly when it looks at how are we building algorithms and what do algorithms tell us about race and racism in healthcare. And I think this is an important aspect because there are structural inequities that are built in. And I think Brad mentioned the social determinants of health. And beyond the social determinants of health, we recognize that oftentimes race has been excluded, or we've had race-blind algorithms, which may be well-intended, but unfortunately, they do not necessarily yield the results that will create disparate or non-disparate conditions and desirable health outcomes. The omissions of race and racial experiences are twofold. And this has been well documented in the literature, particularly in recent findings by Time in its special issue on healthcare, that oftentimes when the algorithm is intended to be race blind, then you actually do more harm in a number of ways by not providing the services or making decisions based on proxies. What I would suggest is this issue of precision medicine, personalized healthcare, there's going to be a need for developing algorithms that understand context, both the clinical side, but also the historic side, because healthcare does not happen in a vacuum. Healthcare is about an ecosystem of education, of housing, of employment, and understanding those conditions within the analytics. Some call it small data, because right now analytics is built off big data, big data, big data. There is a need for some recognition of small data in the paradigm, in the context of developing healthcare applications. And in particularly, if you're going to be entrepreneurial, you're going to need to have that skill set on your team. And oftentimes, I find that with students, they can write great algorithms, they can run great analytical models, but until you understand the context of healthcare, the solutions and the innovation will be absent of meeting the needs of a target or any target population. And so with that, I would just end with saying this. I appreciate the SICK model, Brad. I appreciate the SICK model. I think in the SICK model, the incentives is something that really, when we're talking about managed care and we're talking about fee for service, understanding those nuances beyond and how it impacts beyond medical devices and pharma, we're going to really have to think about what is the innovation at the patient level besides the wearable, because not all patients are connected in such a way that will enable them to have data that can inform the analytics and then also inform an AI development. So I'll turn it back over to John.
Yeah, thank you very much. I just, before I turn it to Aaron, I think that your point that using data is great, but the data doesn't tell us what data to use. And that requires a different level of thinking and intelligence. I really appreciate you putting that point on the table for us. So thank you very much. Let me now turn it to Aaron for his thoughts.
Well, thank you very much. And this is a well-designed sequence of speakers because I want to simply add to what Gillian said and add to what Faye just said and with some additional examples. I am in week 3 of a new role as general manager of new ventures at Aledade. And so I'll reflect a bit on that as well as on 2 prior data science startups that are very much practitioners of the very exciting use of data and analytics in healthcare. Aledade is a company that helps independent primary care practices be more successful in value-based care arrangements. As Gillian said, we need a much more robust primary care infrastructure in this country, and our role in it is to really help small independent practices band together and learn best how to use tools and technologies and clinical expertise to help them earn more money and produce better outcomes for their patients and really serve their community. 75% of our practices are in rural America, and we view it as part of our mission to really bolster the healthcare infrastructure in local places like my hometown of Boone, North Carolina. It's often the small practices, small independent healthcare entities that are employers and that are innovators and that are really key to helping communities thrive. Two quick context points for the other companies I referenced. I'm the co-founder of a company called RxAnti, which uses, still around, but I'm no longer there, uses healthcare claims data to predict whether patients will take their medicine. You can think of the use cases here, the extraordinary effort to produce a new medicine that has been demonstrated to be effective and efficacious for patients. As former Surgeon General C. Everett Koop said, however, patients that don't take their medicines don't benefit from them. And so RxAnti uses a variety of methods to predict and use those predictions to in turn inform the allocation of clinical resources earlier in the therapeutic process to avoid patient discontinuation of their meds as appropriate and support them through the process, rather than waiting until they quit and then trying to talk them back into therapy. You can imagine the use cases in certain areas like schizophrenia and other behavioral health related conditions, but also some of the kind of core chronic diseases that affect so many Americans. Half of folks prescribed a statin take it on time or take it at some level across the year, over the year. There's a lot of work we can do to just get better value from the medicines that we already have. Data and analytics really played a role in that. Second company, Novisci, more recently, is a company in Durham, North Carolina that was just acquired this past December. But my colleague, Alan Burkhart, is an epidemiologist, and I brought this company to market to try to help, again, another data science company that tries to make it more efficient to deploy advanced epidemiological methods to the practical real world of healthcare. So if we want to learn things like, which drug performs better for a given subpopulation with methods as rigorous as those that you'd see that Alan, epidemiologists would publish in a paper, how do we generate tools? How do we build tools that make it possible for those in healthcare delivery to have that kind of rigorous information available to them, not just once, but as data update, recurringly. When I served as chief data officer at North Carolina Medicaid, it always struck me that of how much data we have in Department of Health and Human Services, and yet how little of it is easily accessible to those of us trying to make informed decisions or policy changes. Very simple example, to know what percentage of Medicaid recipients with opioid use disorder are not receiving buprenorphine or other relevant treatments at the clinically indicated duration of therapy can help us figure out how to help those patients. But we don't have that information. To get that information, we would tend to outsource an expensive study to an academic outfit, and they would spend 12 months doing it, and we'd have a really exquisite PDF at the end, but not a document that we can use recurringly to learn what works to improve the outcome we care about. So that's what Novisci was about. So a couple comments, just putting all those three experiences together briefly that I'd like to share. One, there's incredible hope to use the data in healthcare more effectively. I think we all agree that the data is healthcare is data rich. The challenge, though, that I've seen is that we have in the health analytics business, the sector has become more enamored with the methods, the tools, than with the questions that are intended to be solved. So it's almost like, we're excited about the screwdriver, and our job is to go find something to use that screwdriver for, as opposed to trying to clarify what's the problem. What's the problem that what's the question we're trying to answer? What's the problem we're trying to solve? And what's the method that most efficiently solves that problem? Sometimes it's deep learning. Deep learning, AI, these are the kind of important innovations that show real promise in healthcare, but they're more likely to be the subject of headlines about healthcare analytics than what I actually prefer, which is simple counting. A lot of our problems in healthcare are counting problems. That example I just gave you about opioid use disorder is really a counting problem. How many people meet the following criteria and also meet the next criteria? It is remarkable to me how challenging it is in healthcare to get simple counting questions answered. And we don't need really fancy algorithms to do that. We need people who can identify the right questions, think about the policy decisions being made or the business decisions being made, and craft the kinds of questions that will best inform those decisions, and then use whatever methods best answer that. We shouldn't get extra credit for methodological innovation when we really don't need it all the time. When my dad this came to light for me when I was a caregiver to my father, my late dad, who was diagnosed with late stage lung cancer many years ago. Here I am, UNC trained, lots of focus on health policy and data science. And so I've kind of had some assumptions built into the experience of being my dad's son in that experience. We get to my mom and my dad and I sat and heard the diagnosis. And right away, dad is put on kind of a conveyor belt for various times of intervention, chemotherapy and so on. And by no means was I questioning the expertise of the clinicians when I asked this, but I wanted to know this question. And the background of the question, I'll tell you in a second. The background of the question was, I really want dad in his last year of life to be able to hang out with his brother at the beach. I really wanted them, while he's healthy, to be able to do that. So my question to the clinicians was, what percentage of patients like dad, 65-year-old, Medicare, white, former smoker, pretty common lung cancer, stage 4 diagnosis, what percentage of patients like my dad get any kind of chemotherapy in his shoes? And it wasn't that I was trying to inform a particular strategy for chemo or anything like that. I just want to know, is it 2%? Is it 20%? Is it 80%, right? I don't need a lot of precision to help us with this, but I wanted to know, is this worth pushing on a little? Is this the point where we ask, is this the right strategy for dad if we're trying to optimize the quality of life? The reason I share that example in the context of a data analytics discussion is because there was no answer to that question. The clinicians don't have the tools to answer that kind of information. They can tell me what happened in the last 10 patients, but those are anecdotal stories. We have not organized our healthcare data into something that is suitable for answering very simple questions. The other reason I raised that example, personal example, is that question doesn't require sophisticated deep learning and other algorithms. It doesn't require, artificial intelligence. It requires organizing the data, crafting the right question. And by the way, the data are there. Like every health plan would have, every health plan would have this information, assuming they have enough demographic and clinical data to identify patients who are stage 4 in my dad's case. But this was the big insight for me in this field, is that we need to be more humble about the methods and more robust about the questions. And we'll find is sometimes deep learning is important. If we're trying to sort out, 10,000 lab results, and we need an efficient algorithm to help us detect patterns, then simple counting won't do. But a lot of our questions in healthcare are really don't require that level of sophisticated tool. And I think we've got a systematic bias to the more sophisticated, when I think we can make a lot of progress to help a lot of patients if we just use good old-fashioned counting and reward those who help develop an innovation or research that results in informing an actual decision rather than deploying a fancy algorithm that may or may not be useful. So that's not me saying I'm not supportive of advancements in more rigorous analytical innovation. Of course I am. But I think what has dawned on me is we are a healthcare-rich system and a knowledge-poor system. And we can start by getting really clear. If you're starting a company, you need to know what are the questions that are going to make a difference to a business owner. They don't care that you're using a sophisticated algorithm. They want to know, is this going to make me more money? Is this going to lower my cost? Is this going to improve access to customers? Those are the kind of things. And often it's very simple counting questions that can do the job. So hopefully that gives you a mix of both the hope of health analytics, the need for it, but also to push back a bit on the hype. I don't hear that hype today at all, by the way. I'm not commenting on anyone's previous comments, but more of the state of the industry and where it's headed.
Aaron, thank you. Thank you very much.
Sure.
And I think we are moving toward a general discussion, but let me first thank all our panelists for their comments And I really appreciate sort of a common theme that is emerging from different perspectives. You know, as we heard at the beginning, we live in the country with some of the most sophisticated healthcare in the world, with some of the, if not the top hospitals, healthcare institutions, and we have among the worst healthcare outcomes among developed nations because of some of the issues that are being discussed in this panel. And I appreciate that everyone is really, the underlying theme is the inequity that's inherent in our healthcare system, and how do we use data as well as our motivation to really improve healthcare in this in the country we live in and in the world. And I think data can play a role, assuming we follow some of the advice that both Faye and Aaron have given us, and think about, I think, the very helpful framework that Brad put on the table for us. So let me just pause for a moment and ask any of our panelists if they'd like to add any thoughts to the discussion we've had so far, maybe going back to some of the earlier discussants and hearing the notes of warning from both Aaron and Faye.
You know, one thing that I think about a lot, and we think about a lot, is what is it going to mean to work in healthcare over time? You know, we're talking about these, you know, auto magical data sets that are going to make decisions easier. And kind of to Faye's point as well, you know, what does it mean to be on the front lines working with patients? Because we don't believe that this is going to be a world where patients only talking to a computer. They're going to be talking to computers and humans. And, you know, what does it mean to be one of those people? The way folks have been trained in the past, you know, is not necessarily to be a data science expert. And yet there's all this data science coming at them. And so one of the things we think about a lot is what's going on at the educational level. How are people getting the right training? How do we make this transition to in a data rich environment and yet keep, you know, we use the word humanity a lot, but how do you keep the humanity in the care itself? And so I think this is going to bring all new constructs to what it means to be in med school and how you get trained, or not even just med school, but even nurses and all of the other practitioners we use, coaches, et cetera, in our practices, to get them in the right frame of mind where data can be an asset and not an overwhelming problem. Because what we see is it's extremely hard to hire people right now. People are in great demand, they're also overwhelmed. It's just taking care of folks is overwhelming in itself. And then being asked to be a data scientist on the side is tricky. And so we think about that a lot. I don't think we have any answers yet, but we really are trying to think about what does that mean as we get a larger and larger workforce in this space.
Right.
Yeah.
Faye, please.
Yeah, I was just going to say, you know, you raise a great question about what does that mean from an educational perspective. And I recently served as a judge for AI sort of startups, right? And seeing what was being done in that healthcare space within those startups. What was striking to me is very, very, very smart computer science statisticians, but there was still this lack of domain knowledge. And we're going to have to rethink how, particularly if we're talking about training data scientists for a healthcare space, you need domain knowledge. When Brad says to you, fee for service, your student will need to know what fee for service is. And secondly, I would say, while the algorithms may be growing, and I definitely agree with Aaron, sometimes random walk is just the best way to go. I remember my professor saying that many years ago. You know, we did all of this work and to prove that the random walk model was actually the best model. In other words, take the averages and be done, right? And so in this space, what we should really consider is that when we have multiple people, multiple experts from different backgrounds solving a problem, it's going to have to be a team approach to these issues. But the entrepreneurship piece that I was looking at, again, very striking, very smart, very statistical oriented, very computer science, lots of engineers, but still lacking in that domain knowledge. and where healthcare is going and where it has come from.
I mean, I'd love to tap real quick, John, on something both tying to what Faye said and to Aaron. I think, one of the really big kind of comments is this, what problem are you trying to solve? And I think that it's one, as we look at a lot of where innovation and entrepreneurship is happening now, is on very narrow problems that we need to have a question answered, but that it actually, to Faye's point about some of the complexity and looking at the coordination, that it ends up making it worse. And so this is a complaint I've heard from a number of payers, for example, talking about like digital health, that there's an app for everything now. And by itself, that seems like a good idea until you realize that a patient, that has, several comorbid conditions and is trying to manage things more broadly, can't possibly move across that entire space. And so I think if we go back to Aaron's kind of fundamental question, right? What problem are we really trying to help people with? And I think it ties to how Gillian told the story of anchoring things in primary care. Right, then you have kind of that coordinator stretching across all of these elements, and it's part of this challenge as we think about the opportunity going forward. The data can answer these individual pieces, but then as we try to innovate, as we try to create the new ventures, how do we knit them together so that we make it better for patients or for anyone in the system, providers as well, rather than actually making their lives worse in this process.
That is a great point, Brad. And I love the fact that there's this consistent theme of focusing on the real issues, the practical issues, being driven by the problems to be solved, the questions to be answered, rather than falling in love with the algorithms of the technology, which I very much appreciate. I wonder, we have a couple of questions. Let me, there's a question for you, Gillian, that I think is an interesting question for your venture, and in general, for those entrepreneurial ventures that are tackling this problem of creating greater access, higher quality, higher equity in our health system, and how have you thought about that at Iora? And then possibly Aaron, as an investor, how you think about the returns for investment given some of the environment that we live in, the institutional factors, the incentives, et cetera, because it's not necessarily optimized for the model of healthcare that people on this panel are talking about. So Gillian, to you first, please, and then Aaron, maybe you can give us your thoughts.
It's hard to comment on everyone's financials in the space, and I've been at Iora since January. So pardon if I don't know every company, every name, every cash flow, but these are big investment businesses for sure. These businesses are going to take hundreds of millions of dollars. And the issue is one of scale, because ultimately with third-party medical expense, which is essentially our cost of goods sold in a way, is going to be high no matter what population you're looking at here. And so these are fundamentally low margin businesses, which means you have to have scale. So at least when I look at it from an Iora perspective for us, while we've been around for 10 years, we've really been scaling this model for probably about 4 or 5 years or so. And when I look at our patients who've been with us for 3 and 4 years, I feel very good about what the cash flows look like for them. We just need more of them in our mix. And so one of the things that happens in these businesses, the more you grow, the more money you lose, because when you first get a patient, adherence to medicine isn't so great. Staying on diet isn't so great. They're kind of in and out of the system. And one of the things we have to do is both make sure that we're treating all of their issues and kind of getting a holistic health plan together for them. And then in addition, make sure that we're being paid the right amount to take care of them, because we are responsible for all their care. So for us, growth is a great thing, but it's expensive. And so fundamentally, these businesses are going to be based on scale. And fundamentally, there's a bet that these businesses will pay off over time. When you run the math and you look at businesses with millions of patients who are 3 and 4 years with these kinds of organizations, the cash flows look really, really good, but it will take investment. And so in our case, at least for us, it's a matter of getting to the scale. And we are still very, very much in an investment mode at Iora. And, our our friends at Oak are too. And then there's a second nuance that I don't understand as well, and I won't pretend to, that not all of these risk-based organizations have the same customer sets, and there's some differences in geography and exactly which customers they have and what programs they're on. So, you know, I'm not as well versed in that relative to some of the others in the area, but certainly some of the businesses where you're targeting specific geographies and specific types of patients can get profitable a little bit more quickly because it's a more common model across them. On the broad base, you just have to get to scale. That scale is the only way you'll get cash flows over time. And that is the big entrepreneurial bet in this space. And so far, investors are really willing to bet behind that, but that's the risk and the potential reward of the space as well.
Great, great. Aaron, would you like to add anything to that?
Yeah, I think I would say that that value-based care is kind of a buzzword, but it really does mean something. It means that we finally started the process leading with Medicare because it's the biggest payer, but we've seen a fast follow by commercial insurance arrangements. It is a lifeboat from a prevailing fee-for-service paradigm that kills innovation. If you are a business that lives on the 15-minute treadmill of taking care of patients in short clips because you've got to satisfy the billing gods and submit enough claims to get enough revenue that exceeds your costs, you're not thinking about innovation. You're not thinking about what Gillian and team are doing. You're not thinking about redesigning how do we want the system to be for our own parents and our own families. That's impossible if you're in a fee-for-service dominated system. And amazingly, and I'm knocking on wood every day, the changes that we've seen in value-based care that do, of course, come from a long lineage dating for decades back to new care, payment and care models, even in the 70s and even before. But the most recent, chapter in the value-based, journey really started with the Affordable Care Act and perhaps the High Tech Act, if I can be, having been involved in the High Tech Act, if I can say that, because it produces a more level information ecosystem. To have electronic health records more broadly used is crucial. We need information to flow. But then the Affordable Care Act has a number of new, not just pilots, but new payment paradigms that have spawned, multi-billions of dollars of new companies like Aledade, like Iora, like many others that are trying to use the freedom afforded by value-based payment arrangements to rethink how to organize medical care. And so my knocking on the wood moment is that has survived. There's some really good evidence now from the Affordable Care Act that particular models, and I'll say physician-led ACOs, are consistently the biggest winner of all the tests that CMS has done, partly because it's really complicated to put hospitals in an ACO construct when lowering the cost of care means cannibalizing their core revenue and their core business model. But there are many hospitals trying hard and doing well in various ways to use the gift of value-based care to rethink how we want to move money around, how we want to invest in things that there's no billing code for, but to do so knowing that there's a potential way of capitalizing those things through value-based arrangements. So I would say critical to all this is really good information. And we don't have great information now, as we've all been saying, but we have a lot more information than we did when everything was written down and neatly organized in manila folders. And we don't have, our value-based arrangements today are not monolithic. They're not in every market. They vary by payer. They vary in a lot of ways that are kind of idiosyncratic, but there's enough movement to really see the promise of innovation of companies and investors willing to try in this new ecosystem to test theories about what care could look like. And I think, there's a whole, even in just the last 2 weeks, a number of IPO announcements of such companies that would not exist without without some alternative to pure fee for service. Certainly Aledade would not exist. If we were trying to provide clinical support and data support and technology at no cost to practices, with a business model that says we will only get paid if you get paid more. That is, we will only get paid if we help you become successful in value-based care, and thereby you, the practice, earn more money. That business model doesn't work if we're just in fee-for-service. Practices don't have enough money to buy anything by design. So I think my comment is all of this stuff that we're talking about, all these innovations and uses of data really are, at least I wouldn't say predicated on value-based arrangements, but they're certainly rocket fuel to the kind of innovation we want to test and see in healthcare. And there will be a lot of companies that will continue to try, and some will fail. But I think overall, there's an ecosystem of I'd say competitor. I mean, we would look at the Iora and say, we want Iora to win big, right? Because it's a big ocean. There's a lot of new things to learn. There's a lot of needs. There's a lot of primary care deserts around the country that don't have enough of anything. So I'm excited about that. And I think we have a lot to learn, thanks to advancements in data, thanks to advancements in payment, and thanks to the grit and ingenuity of people and clinicians trying to make it better. So I'll leave you for that.
Thank you.
A note of hope there.
Yeah. Thank you. Well, not quite the end yet. So Gwendolyn has asked a question that a very specific question that I don't know the answer to. Let me ask whether anyone knows the answer to the question of whether the Biden's infrastructure plan addresses the need for better health care. For better healthcare analytics, and I think that might be a good opening for the question that is very challenging for some entrepreneurs to deal with the relationship between policy and evolving policy and opportunities for entrepreneurial ventures, which is probably more dominant as a set of considerations in healthcare than in any other space, because there's so much policy that is sort of on the horizon, seems to make sense, but whether it'll happen and whether it'll create these opportunities remains a big question. So let me ask first whether anyone knows that whether the infrastructure bill addresses healthcare analytics, and if not, let's just speculate on the broader question of the relationship between policy and entrepreneurship in this space. Faye, do you?
So yes, so Jean, I think someone actually wrote, oh, was that you, Aaron? Yeah, it was yes, with regard to broadband. And
yeah,
with regard to, so with regard to broadband, which becomes
right,
even more important. So yeah, that's all I was going to add to that. You were going to ask a question.
Well, so since you have the floor, and as you advise entrepreneurial ventures, how do you get them to think about evolving policy, some of the issues that Aaron has put out there as we move to fee for service? How do we get paid? We have healthcare delivery systems that are so dominated by the fee for service model, and really, for good reasons, they have to survive. Yeah. So any thoughts on that?
Yeah, in terms of policy, I think one of the things that comes to mind when it comes to entrepreneurial ventures is that, yes, if you're creating a model, whatever technology or innovation that you're putting out there, the results that you are getting or the impact of your work, how can you better inform health policy for sure? And beyond the health policy, we need to think about the point that data is just the starting point. And so where can there be what I consider policy when it comes to humans being in the loop? So the human into the loop sort of perspective is something that I would offer that entrepreneurial ventures will think about in terms of informing policy. While the applications may be generating recommendations or decisions, there's still a need for human ingenuity and weigh-in, and hopefully the policies that will be created from that will certainly support that human intervention.
Yeah, that's great. It harkens back to Gillian's point about the humanity and the care as a core part of their business model. Yeah, thanks very much. Anyone else want to offer thoughts on evolution of policy and how entrepreneurs should think about that as they create innovations and try to go to market with companies that improve healthcare?
Sure. I mean, I'll jump in quickly. I mean, the first statement I think is the most obvious, which is, you know, in healthcare, you can't ignore the policy element. And I think a lot of entrepreneurs and folks with traditional business mindsets, especially when they're new to healthcare, do that, right? And so just appreciating the government is inherently linked, given its critical role as a payer, but also as often kind of the policymaker that then flows through. You know, I think with that being said, you know, the similarity to other settings is, you know, an entrepreneur needs to look at how they're going to get paid, right? And that's, you know, true in fill in the blank, any space. And so there are plenty of ways to get paid in fee for service. You just have to line up into that, right? And where is the margin coming from? If it's, you know, kind of you're looking at vaccines, well, you realize this is the reimbursement they're getting, or this is the loss that comes from not having inventory. And so now we have, even though it's not a value-based payment, now we're providing real value to the primary care clinic, and therefore kind of there's a money stream to come back our way. And so I think that is sometimes the challenge in healthcare is folks get so excited about the solution, a little bit back to Aaron's, you know, we've got a hammer, everything looks like a nail, and they neglect to think about, well, follow the money. And so those, you know, purpose and dollars need to come together for healthcare entrepreneurship to work successfully.
Great thoughts. Thank you very much. Well, we have 4 minutes left. I think this has been a wonderful discussion. I thank you all. And let me just ask each of you if you have a final thought for the audience. I really appreciate this conversation so far. Gillian, let me start with you, and then
just grasping for a final thought. Now, look, I think we're very much early days in some of these new business models of healthcare, and I think key in my mind is balancing the new business models of healthcare with the better outcomes and better results, which is what it really is all about. And so, you know, that balance is one of the trickiest moral balances, I think, of the business we are in. And I'm really hoping that, you know, all these great minds can collectively get to really great answers on it.
Great. Gillian, thank you very much. Faye, how about you? Any?
Yeah, just as a parting word, I'm going to go back to Aaron's ask the right question. I like that idea. Ask the right question, and in answering those questions, center equity in asking the right questions. Where's the equity? Because one of the things that was mentioned here is that oftentimes the innovation is biased in the fact that it's the innovation. And there are other biases that creep in as well. And so centering equity at the foci of the innovation and asking the right question are key.
That is terrific. Aaron, it seems like that's a great segue to your final thought. Thank you, Faye.
Yes, this has been a great learning opportunity. I guess I would just end by reminding us that Yahoo search used to be the way we searched for information, and no longer, most of us have forgotten that it exists. And that just means things evolve, and innovation means we companies and ideas need to constantly iterate and need to constantly assess what value they're creating. And we are all people who are comfortable with that kind of change mindset. That just because we learn something today doesn't mean that 5 years from now it will be as popular as it is now. So this is a tough environment to be in, but an exciting one. I'm really hopeful about the key contributions of data, payment change, innovation, delivery models that really can hopefully do something important and meaningful in our healthcare system.
Aaron, thank you. And Brad, to you for a final thought, please.
Sure. I think I'd go back to thinking about partnerships. that I think creative destruction looks different in healthcare because we're talking in delivery in particular, is we're talking about people's health. And so kind of simply removing a player and making them disappear when they're so critical in that infrastructure, it may happen eventually, but it rarely happens instantaneously. And so kind of how can we bring together the new ventures, the existing players centered around the patients, often those who've been left behind, in order to improve the overall system.
Brett, thank you. Well, let me just thank all of our panelists. Really, really thoughtful, stimulating, wonderful discussion. Thank you all. And thanks to all of you that attended. I hope you found this worthwhile. Thanks to the Kenan Institute, the rest of UNC. Such a pleasure to be with all of you. Thank you again. Take care, everybody.
Thanks, John, so much. And thank you, panelists. That was wonderful. I think y'all really highlighted, a lot of the things that are specific to healthcare, both the opportunities and the challenges related to scale, related to equity, related to how to leverage these new evolutions. So thank you so much for bringing all of your expertise and engaging in a really great conversation for our audience. John, thank you for moderating, and Maka, thank you so much for setting up the panel with all of your research that you put into the trends report. So audience, thanks for being here. Thanks for hanging in. So we are 3/4 of the way through the conference. So we are going to now go to a break until 12:40. So you can just, come back to this room. We're going to put, a hold screen, and we'll come back on here at 12:40, or you can close it down and then re-access it through the agenda. Until then, you can also connect with us on Twitter, #KIVE2021.